Hi, my name is Sevak Olmesekan, and I'm here to present patient case number 1 about dyslipidemia and prediabetes. A 57-year-old Caucasian female seen today at the clinic to establish care. Erin Wilkinson is a 57-year-old Caucasian female who was seen today, November 2nd, 2017, in the A.F. Williams Family Medical Center, and she made an appointment today to establish care because her insurance company forced her to find a new provider. She has not seen her previous provider in over 10 months and would like to get refills on some of her medications. When she was asked about her adherence specifically, she states that she has not taken any of her medications at all in the last few weeks, but realizes that she is not that what she's doing is not good for her health, and she indicates that she would like to start back only on the medications that are necessary for her to take better care of her health. With respect to her blood pressure, she states that she does not measure her blood pressure at home, but would like to get the blood pressure measured on a more regular basis. She says that she has reached a point in her life that she would like to take more control of her health and is willing to take any medication or undertake any lifestyle modifications that will help her to do so. Her past medical history includes hypertension, hyperlipidemia, hysterectomy in June of 2012, laminectomy L2, L1 in April of 1995, and her last influenza vaccination was in 2012. Her family history includes her mother, who's alive with hypertension, MI, and dyslipidemia. Her father is also alive with hypertension, dyslipidemia, and a history of melanoma. Her brother with MI at age 62. Her social history includes that she walks her dog around the block once a day and there is no more exercise. She loves fast food and she doesn't drink or smoke. Her vitals and labs today include her weight at 200 pounds, height is 63 inches, temperature of 98.3. Her blood pressure is 162 over 98 and 165 over 96 when repeated. Her A1C is 6.4 seconds, 6.4%. 2-hour glucose challenge is 179. Her HDL is 30 and LDL of 160. Her medications include lansoprazole 30 milligrams daily, aspirin 81 milligrams daily, and she takes over-the-counter fish oil twice a day. She's allergic to sulfa, but with an unknown reaction, and her problem list include hyperlipidemia, hypertension, and prediabetes. In assessment of her disease for dyslipidemia, patient's lab values indicate that she has hyperlipidemia, which currently is not treated with any means. Her exercise is less than the 150-minute moderate aerobic weekly recommended exercise, and she is not on any pharmacotherapy. Patient's calculated 10-year ASCVD risk is 7.5%. According to the ACC-AHA guidelines, this patient fits in one of the 4 major benefit groups for statin therapy, and the group is the patients without clinical ASCVD or diabetes with an LDL cholesterol of 70 to 189 and estimated 10-year ASCVD risk of 7.5% or higher. The plan and recommendations for dyslipidemia is that the patient needs to increase exercise activity with a goal of 150 minutes of moderate aerobic activity weekly. And per U.S. Preventive Service Task Force guidelines, with a 10-year ASCVD risk of 7.5%, the patient should be on aspirin 81 milligrams daily, which she is, and based on ACC-AHA guidelines, her family history of CVD, and as well as her C-reactive protein of 3.6, she should start on a moderate to high-intensity statin therapy. An appropriate statin for this patient would be an atorvastatin 40 milligrams daily. The rationale behind these measures is that by lowering the LDL cholesterol and overall improvement of the lipid panel, we would reduce the risk of major cardiovascular events. In terms of monitoring parameters, for the safety measures, the patient's liver function tests, AST and ALT at baseline and periodically throughout therapy. Renal function should be measured in the event that renal insufficiency develops by worsening diabetes. Serum creatine kinase to monitor myopathy, and for efficacy measures we need to monitor the lipid panels, 2 to 4 weeks after initiation and 2 to 4 weeks after any dose adjustments, should there be any. As for patient education, the patient needs to be educated about the signs of liver problems, which include dark urine, fatigue, lack of appetite, nausea, abdominal pain, and light-colored stools, urinary retention, change in amount of urine passed, severe loss of strength and energy, severe joint pain, severe muscle pain, tenderness, or weakness. In terms of her prediabetes, according to the ADA, prediabetes is defined as hemoglobin A1C level of 5.7 to 6.4%, or a 2-hour glucose tolerance test of 140 to 199 milligrams per deciliter. This patient is at the higher end of the A1C range, which is at 6.4%, and has a 2-hour glucose challenge value of 179 milligrams per deciliter. And these values categorize this patient as pre-diabetic. And this patient also possesses several other risk factors for prediabetes and type 2 diabetes, according to the ADA, which include the A1C of 5.7% or higher, first degree relative with diabetes, hypertension, HDL cholesterol of less than 35 milligrams per deciliter, and obesity. Patient's calculated BMI is 35.5, which categorizes the patient as obese. According to the 2017 ADA standards of medical care in patients with prediabetes, other CVD risk factors should be identified and, if appropriate, be treated. It's a B recommendation. And ADA recommends measuring fasting glucose every 3 to 6 months, it's an expert opinion, to monitor for progression of diabetes. ADA has an A recommendation for intervention programs that facilitate modest weight loss that is achievable by combination of lifestyle modifications and reduced calorie intake. For overweight and obese adults, ADA also has a B recommendation for a variety of eating habits that are acceptable for diabetes and prediabetes, such as DASH, Mediterranean, and plant-based diets. There's also an A recommendation for referring pre-diabetic patients to intensive diet and physical activity behavioral counseling programs to adhere to a target of 7% loss in body weight, and that they should increase their moderate physical activity to at least 150 minutes per week. ADA has an A recommendation for treatment with metformin to prevent type 2 diabetes in those patients with prediabetes, especially for those with a BMI of 35 kilograms per meter square or higher, age of less than 60 years, and those with a rising A1C despite lifestyle modifications. So the recommendation would be to refer the patient to an intensive diet and physical activity behavioral program. We need to emphasize the importance of the proper diet and regular physical activity. We need to also initiate metformin at a 500 milligram twice daily with meals. As far as the monitoring parameters, for safety, we need to monitor the eGFR prior to initiation and annually thereafter, and a baseline and annual hematologic tests, including hemoglobin, hematocrit, and red blood cells. We also monitor serum vitamin B12 levels every 2 to 3 years. And for efficacy, we need to monitor the glycemic control, the A1C, and self-monitoring of blood glucose. As for patient education, we need to let the patient know that they may experience diarrhea, flatulence, nausea, or loss of energy. And they need to immediately report signs of lactic acidosis, which include fast breathing, tachycardia, abnormal heartbeat, vomiting, fatigue, shortness of breath, and feeling cold, muscle pains or cramps. And signs of hypoglycemia include dizziness, headache, fatigue, shaking, tachycardia, confusion, increased hunger, or sweating. As for patient medication list, the drugs that patient needs to be on is aspirin 81 milligrams one a day, atorvastatin 40 milligrams one a day, metformin 500 milligrams one BID, and fish oil over the counter 500 milligrams one BID is appropriate to continue. Since there is no indication provided for the use of lansoprazole the patient's lansoprazole should be DC'd. And as for her blood pressure, the blood pressure needs to also be addressed, and according to the ACC-AHA guidelines, the patient should start on a thiazide diuretic such as a hydrochlorothiazide, 25 milligrams daily, be placed on either an ACE or an ARB inhibitor, such as lisinopril 10 milligrams daily, and a calcium channel blocker like an amlodipine 10 milligrams daily. The doses of all those medications could be adjusted based on the patient's response to that specific therapy. In conclusion, there are several studies and in the literature that I found that support this approach. First of all, to start from the top, the goals of diabetes prevention include delaying the onset of diabetes, preventing beta cell function, and preventing or delaying the microvascular and perhaps cardiovascular complications. And as a therapeutic target, prevention of beta cell function is particularly important because beta cells are largely underlying the transition from prediabetes states to diabetes. And in order to identify people or patients who would benefit from preventive measures, they need to be the factors that need to be measured and monitored are the A1C and the fasting plasma glucose levels, and specifically in pre-diabetic patients who are individuals who are more than 45 years of age with a body mass index of more than 25 kilograms per meter square, who have one or more of the following: a family history of diabetes in a first-degree relative, sedentary lifestyle, gestational diabetes, hypertension, or dyslipidemia. And if the fasting plasma glucose or A1C values are abnormal, they need to be repeated just to make sure that the values were not falsely reported. And the patients with impaired fasting plasma glucose and A1C of 5.7 to 6.4% should be recommended for lifestyle changes and healthy diet and exercise. Abnormal diabetes clinical risk factors include obesity and family history, and people with those are even in a higher likelihood of developing diabetes. And all patients at high risk should be provided with comprehensive lifestyle modification programs that include the behavior modification, dietary therapy, physical activity, and smoking cessation. American Diabetes Association recommends lifestyle modifications as a primary intervention, and because of its effectiveness, low cost, and long-term safety, the American Diabetes Association recommends consideration of metformin to prevent diabetes in individuals at a higher risk for developing it. And in addition, assessment for and the treatment of moderate cardiovascular risk factors such as hypertension and dyslipidemia is important to reduce cardiometabolic risk. And patients who treated with metformin require at least an annual A1C and fasting glucose measurements. And there are some other studies too, one performed by Balk and colleagues titled Combined Diet and Physical Activity Promotion Programs to Prevent Type 2 Diabetes Among Persons at Increased Risk, a systematic review for the Community Preventive Service Task Force, concluded that the combined diet and physical activity promotion programs are effective at decreasing diabetes incidence and improving cardiometabolic risk factors in persons at increased risk. And also another study by Parker and colleagues titled The Effect of Medical Nutrition Therapy by a Registered Dietitian Nutritionist in Patients with Prediabetes participating in a randomized controlled clinical research trial, which the primary outcome measure was fasting plasma glucose, and secondary outcome measures were the A1C, serum lipids, and diabetes risk scores, concluded that the results demonstrated that individuals with the therapy is effective in decreasing the A1C levels in patients diagnosed with prediabetes. Also, the Diabetes Prevention Program Research Group has a published article titled 10-Year Follow-Up of Diabetes Incidence and Weight Loss in the Diabetes Prevention Program Outcome Study. And a 10-year follow-up of the subjects show that during the follow-up after the treatment, incidences in the former placebo and metformin groups fell to equal those of the former lifestyle group, but the cumulative incidence of diabetes remained lowest in the lifestyle group. And they conclude that prevention or delay of diabetes with lifestyle interventions or metformin can persist for at least 10 years.